So I wanted to first put into context the HAI program within the Department of Public Health. So the Department of Public Health lies within the the Division of Health and Human Services, and the Chief Medical Officer and Director of the Department of Public Health is Dr. Tom Williams, and he's here, and without his support, did he have to go? I think he might have just slipped out. Oh, there he is, there he is. But without his support, our programs would not flow or function. Within Department of Public Health is the Epidemiology and Informatics Unit, and then within that is epidemiology, and Dr. Tom Safranek is our state epidemiologist, and again, without his vision and his support, the HAI program would not be in existence. But the HAI program is not just the folks who are based in Lincoln at the Department of Public Health. We have collaborations and partnerships with many groups, in particular with ICAP that Kate just talked about, which is based at Nebraska Medicine, ASAP, which is also based at Nebraska Medicine, and who their hard work brings you this day. MD Stewardship, which is a tele-stewardship program with individuals primarily based at Creighton. The Nebraska Public Health Laboratory, and I know we have laboratorians here as well. Our relationship with them is crucial in detection and containment, and we also have a safe injection program. So those of us that are at the Department of Public Health are myself, Caitlin Padati, Dr. Padati, who we just mentioned. I know many of you have worked with her on outbreaks. She is so fantastic that she's brought our program to another level, but unfortunately, she's leaving to become the state epidemiologist in Iowa, which is great for Iowa, but not great for us. So we'll have one last chance to hear her expound on the work that she's done. And then Margaret Drake, who's here, who's an infection preventionist and NHSN expert extraordinaire, and I know many of you know Margaret. We're supported by our EIS officer, Dr. Free, and a wonderful informatics group. So what is the goal of, or the goals of our program? And I've listed the goals here, and the ones that are underlined are the ones that I think particularly connect to stewardship. So our goal is to monitor and reduce healthcare-associated infections, to support stewardship and infection prevention assessment around the state, to provide education for the public, primarily through our website, but in other ways as well, educational resources for healthcare workers, a coordination of infection prevention improvement and antibiotic stewardship, detect outbreaks and resistance, and then also to manage and contain those outbreaks and resistant clusters. So the first thing that we can do is provide general support. And Dr. Srinivasan talked about be antibiotics aware. And every year, the CDC sets aside a special week that they call Antibiotic Awareness Week. Used to be the Get Smart campaign. Now it's Be Antibiotics Aware. So we decided, let's get our highest government officials involved in recognizing how important stewardship is. So this is a picture of many of us that I've just mentioned, and Dr. Ashroff is there, Kate's there, Dr. Safranek, Dr. Padati, Margaret, folks from GPQIN, and Dr. Williams, as you can see, is right there. It was to have the governor sign a proclamation which declared that same week Antibiotic Awareness Week in Nebraska. In addition to that, we had educational displays and campaigns that were based at the state capitol, a press release, some radio interviews, and we want to do that every year. And next year, we're going to go into middle schools to actually do a little education there. I think one of the most important things we do, sometimes I like to say we're the money, but we actually help support getting funding. Because obviously if we're not funded, this great work can't continue. So our funding comes from something called the Epidemiology and Laboratory Capacity Grant, and there's a section of that for HAI. And that's our primary source of funding. And we have to put in a really extensive, laborious grant proposal every year, and I become I can't remember whether Jekyll or Hyde, which one's nice and which one's not, but I become the not nice one for about 6 weeks in April and May as we coordinate all those applications. But we look for other sources as well. Anybody who wants to give us money to do stewardship, we'll take that money. So Agency for Healthcare Quality and Research, CMS, IDSA, CSTE, and then some other programs within the CDC. Our partnership, as I mentioned, I'll mention a little bit more specifically. So within the Department of Public Health, the EPI section at this state, we get a lot of support from our informatics group in terms of electronic lab reporting, the registry that Dr. Badati is going to talk about. Sometimes we work in coordination with other epidemiologists. For example, if there's a hepatitis outbreak in a healthcare facility, there's a hepatitis epidemiologist. When I say other EPIs, I mean epidemiologists. That's our short term who work in those areas. We work closely with local health departments. There's a lot of superb local health departments in Nebraska, and we will work together with them. I think one of the reasons Nebraska's been so successful in stewardship is some of what I call our public-private partnerships. So UNMC obviously is part of the University of Nebraska system. Nebraska Medicine is private, and so our connection with Nebraska Medicine has created the Antibiotic Stewardship and Assessment Program, ICAP, and that's been extremely successful. Another connection with MD Stewardship, which provides some telestewardship to rural access hospitals. Again, the Nebraska Public Health Laboratory has a unique relationship with the Nebraska Medicine Laboratory. Actually, they're located on the same floor in the same building, and there's a door which sort of divides them. But it allows for efficient collaboration and great communication between us and NPHL. We're also developing, have some now, and are developing some further relationships with the College of Public Health. Dr. Ali Khan is the dean, and Dr. Deborah Levy, the head of epidemiology. And that's the last of those public and private partnerships. I want to give you just or mention a few examples of the way in which those partnerships have worked, where you needed someone, let's say a state coordinator, to kind of make it happen. Dr. Srinivasan talked about the NHSN AU-AR enrollment. He particularly was talking about AU. Well, we've worked and helped get funding, and right now Nebraska Medicine and Creighton are actually flowing that data. It's very expensive, it's very laborious. It took a year probably, right, from the date, Trevor, from the time we started until it actually happened. So it's absolutely fantastic, but it's kind of a little harder than Arjun sort of alluded to sometimes. But that's something we really had to work together on. We've had summits to recommend the appropriate CDI testing. We leave that up to particular facilities, but there are clearly some recommendations on the best way to go. And then one area that we're particularly proud of is developing, with the collaboratory work, a transfer form to try and decrease resistance going from one facility to another. Now, there are other transfer forms out there. This is a poster that's actually going to be at CSTE, the Council of State and Territorial Epidemiologists, in just a few weeks. But what we found is that we needed, and we did this with work from infection preventionists, nurses, physicians, emergency medicine technicians, is we wanted something that was so simple, because there was a problem when people would go from one facility to another, that the information about someone needing isolation or contact precautions, all of a sudden, oops, it's 6 hours later or a day later, and that information hadn't been transferred. But we don't want to create too much extra work. So this is an extremely simple form. Pictorial is always the easiest way to go. But this was the result of tremendous collaboration with the goal of reducing interfacility transmission. So as I already mentioned, public education and awareness creates overall support, and therefore can translate into political support for some of the efforts we want to make. This is our website, and on the prior page, there's actually, the website is listed, and it's in your handout. And our website has sections. It just keeps getting, it's getting a little too big, I think, for now, but it has sections for both the public and healthcare professionals, and obviously the public can go to all those healthcare professional pages. And it has, in addition to information there, it has links to resources. And it links to our other partners. So you can go to our website and get a link to MD Stewardship, to get a link to ASAP, to get a link to ICAP. And in addition, healthcare professional information. So the information on CRE, on our antibiotic data susceptibility registry that Dr. Badati will talk about, is also on there. Again, it also links to those other partners that I talked about. So some of the coordination also involves trying to know who is doing what. So we obviously are getting funding, our partners are working on other things. Other stakeholders, like the QuinnQIO, the Nebraska Hospital Association, and the HIN, the Office of Rural Health, are also getting funded and having efforts. And one of the things that we try and do, and that I and our office in particular do, is to try and determine who is doing what so we don't duplicate efforts. Because the funding, there's more than enough for us all to do, and we want to make sure we're efficient. But I think the area where we can most particularly help is trying to determine where to focus stewardship by detecting individual cases of highly resistant organisms, by finding clusters, and also being able to detect and follow CDI rates. So that actually starts. If you're going to be able to detect something, you have to have it reported. So on January 1st, 2017, actually I should go back. In 2010, Dr. Sofranek was visionary and added a number of gram-negative organisms that might harbor carbapenem resistance to the reportable disease list. And then in January 1st, 2017, we added HAIs, we added carbapenem-resistant organisms, and other additional organisms that might harbor some particular concerning resistance. But when I say that, it actually sounds like, oh, that's easy. Many of you know me that it took about 3 years to actually make some changes, well, maybe 2 years, the reportable disease list. But we finally got the governor to sign that, and it went into effect January 1st, 2017. And I have to tell you, we were in the top 20% of states making CRE reportable. So we should be proud of that. So just to go back here, also on the website on epidemiology, so this is not the HAI website, but the epidemiology part of the Department of Public Health, is listed the reportable disease list, and is also listed this really nice chart that is used primarily by laboratories. And again, the laboratory relationship is key. We have quarterly calls with all the labs in the state led by the Nebraska Public Health Laboratory. This is a chart that laboratories use that can differentiate, and it's also color-coded to help you determine, gee, what do you need to report immediately? What do you need to report within 7 days? What organisms need to be sent to NPHL? So these are some of the organisms we in particular wanted to make sure we knew about. So all organisms that could potentially harbor carbapenem resistance, particularly CP-CRE, so I'll talk about that in a minute, and carbapenem-resistant Pseudomonas. We want to know about anything that's pan-resistant or anything that has colistin resistance, anything that might be intermediate or resistant to vancomycin, and then anything that might be Candida auris. So this is actually the wording from our reportable disease list. So there are the organisms we really want to know about fast, and then it's really time sensitive that we know about them, are in the report immediately or within 24 hours. So anything that's carbapenem resistant, that might be, so if you are a lab that can do carbapenemase, the wording will be changing to be carbapenemase resistant or, Enterobacteriaceae determined or suspected. Any vancomycin intermediate resistant staph, and then we will also have colistin resistant and pan resistant organisms, and anything suspected to be Candida auris when we get through this next regulatory hoop to add those to the reportable disease list. In addition, we have a lot of information that comes through our electronic lab reporting. And this whole process is so much more complicated than I thought about when I naively started to look at electronic lab reporting. Again, Dr. Sofranek and Dr. Badati, Dr. Sofranek sort of started this, and she's worked on this to make our ELR really effective and useful. And one of the things that both Dr. Srinivasan and Dr. Dinkama were referring to is, when you talk about how hard it is for laboratorians and the amount of work and recognition they don't often get, and the informatics people who work with them. If we make something reportable that is broken down by antibiotic susceptibility, that becomes tough. So we really limit that. But if we ask that a whole species or like a whole genus be sent to us, that's actually relatively easy informatically. The challenge then, what happens is that information comes to us, and then Caitlin's going to talk about how we can look at that by antibiotic susceptibility to make it more useful. So that's why these pathogens are reportable via ELR only, and then those need to be reported within 7 days. All C. diff is actually reportable in the state of Nebraska, and then Mycobacterium species are reportable because of outbreaks that have occurred with non-tuberculous mycobacteria, obviously as well as concerned about tuberculosis. So I want to talk a little bit more specifically about carbapenem resistance, because that's the thing that the bug that we really, really want to keep at the place we are now. When I go to national meetings about HAI and antimicrobial resistance, our colleagues in Chicago and New York are overwhelmed with the amount of carbapenem resistance they have, so much so that they don't even test them anymore for the presence of carbapenemase because they can't do it. It's not possible. So we want to stay where we are right now. So this may be basic for many of you, but to just make sure we're all on the same page, carbapenem-resistant Enterobacteriaceae are gram-negative organisms that have the potential to reside in the gut. Whether they normally do or not is different, but are resistant to the class of drugs called the carbapenems. Some of those organisms actually produce their resistance by the presence of a carbapenemase, and that's what was referred to as CPCRE, or carbapenemase producing carbapenem-resistant Enterobacteriaceae. Now some folks refer to that as CPO, or carbapenem-producing organisms. But they all lie under the umbrella of carbapenem resistance. So carbapenem resistance, as I mentioned, isn't always because of a carbapenemase. It might be because of a loss of porins, an AMC, or a certain kind of ESBL. About a third of carbapenem resistance nationwide is secondary to the presence of carbapenemases. And why does that make us nervous? It makes us nervous because the carbapenemases, the genes for that, are located on movable genetic components. So our concern, and Dr. Padati will talk a little bit about containment for that, is that the concern is that they can not only move from one bacteria to another within a species, but from species to species. So one of the particular nightmares is you get a highly resistant Acinetobacter that's hanging out with a carbapenem-resistant Klebsiella. They might get a little too friendly, and then you can end up with a pan-resistant organism. So that's one of the reasons we kind of get all hot to trot about that. To detect carbapenem resistance, there's two major types of testing. I'm not going to go into those specifically, but there's phenotypic testing, and that tells us, okay, we've got carbapenemase production. And then there's molecular testing that can tell us which carbapenemase that is. Now, just last week, there was a meeting at the Regional Laboratory Network, which is actually there are about 7 regional laboratories around the country funded and supported by the CDC. And one of our laboratorians actually went to Roxanne Alter, went to that for us, and I attended actually via phone, and some very interesting information came out of that meeting. It looked both nationwide and then in the central region as to what kinds of carbapenemases you are seeing. And I've highlighted that nationwide, KPC, or Klebsiella pneumoniae carbapenemase, is 90% of the carbapenemase you're seeing nationwide. And we'll talk about the central region. I'm sorry, here I actually have CRE and then CRPA, or carbapenemase producing Pseudomonas aeruginosa. And there, the most common organism is a VIM. This is a chart for 2017, the number of carbapenemase producing CRE, or the number of CRE that we've seen in the state of Nebraska. Now, we've been reporting, the numbers are pretty low. It was 7 as of December.
We've actually had 2 more within the past month, so we're up to 9 in about a 14-month period. But that's a little, thankfully it's not crazy, but it's a little higher than we had expected. We expected maybe 1 or 2 a year. So we're probably at about, as we said, 6 or 7 or 8 at a year. But that's where we want it to stay. If you look at the number of isolates by state in the central region, Iowa and Kansas have a lot more than we do, but Iowa and Kansas have more people than we do. This number is a little bit low, but it gives some general perspective. Nationwide, we're talking about much larger numbers. This is the slide I was mistakenly referring to before, but it actually shows something that's been seen for the whole central region, that the percentage of the non-KPC, so when you look at the carbapenemases that I listed before, the 5 of different kinds of enzymes, the most common by far is KPC. And that's actually what's seen, for example, in New York, 90% of the time. So if you look at these numbers, the percentages are actually the percentages of all CREs that have a carbapenem, a KPC, or an NDM. So in the central regions, we're seeing more actually VIMs, okay, or maybe NDMs than we're actually seeing KPCs. So there's a different pattern of what kind of carbapenemases we're seeing here. And there's a particular concern about IMPs because it appears, or imipenem metallobeta-lactamases, because they may have some association with agriculture. So that's something we're really looking closely on. And so these give you the particular carbapenemases that we've seen in Nebraska. So again, if you look at them, more than half of them are non-KPCs. We are actually participating in a non-Big 3, or I should say really, I mean we are, but it's primarily the Nebraska Public Health Lab and Dr. Caitlin Murphy who's been working on this, because the CDC is really interested in the source of these non-KPC carbapenemases. And it appears that Citrobacter and Providentia, Proteus, and Serratia are the 4, and we say the non-Big 3. The Big 3 are E. coli, Klebsiella, and Enterobacter. So any other Enterobacteriaceae that's not one of those 3 is considered the non-Big 3. The CDC is also very concerned about carbapenem-resistant Acinetobacter. This slide is in your handout to sort of have as a reference, but one of the concerns, again, is we want to make sure that we keep these very resistant organisms away from each other. So the containment strategy, the CDC put out a vital signs about 2 weeks ago, which talked about ways to try and screen and contain for highly resistant organisms. So clearly, one of those organisms is carbapenemase producing organisms that Dr. Padati will talk about detection and maintenance of, or maintaining those so that they don't spread. But they also are concerned about pan-resistant organisms, organisms that carry a gene called MCR1, which codes for colistin resistance, and then anything that is suspected to be Candida auris. Candida auris could have a whole new talk. We haven't had any in Nebraska yet, but we'll, next year, maybe, we'll talk about Candida auris. I'm going to turn the slides over now to Dr. Padati, who's going to talk about outbreak detection and management.
Thank you. And here's our clicker, perfect. So, you know, as former CDC, EIS, my favorite thing is outbreaks. So I'm not going to be the most experienced person on stewardship by any means, but I really find outbreak scenarios, responses, the way we manage them to be really fascinating. And, you know, that's where I've really started to lend a lot of support to the HAI program. So what we're going to talk about is how in Nebraska we approach sort of these kinds of outbreak scenarios. And I think that what you'll find, you know, we've kind of developed our own picture up there, but I think that what you'll find is that we really try to take a pretty collaborative approach. So I think you've heard several times today that this kind of work, and I'm sure you all know, in doing this, it's really not one area. It's not something that one person can own, right? You know, you've heard from laboratorians, you've heard from, people in infection control, clinicians, infection preventionists, pharmacists. All of those people play a really important role in mounting these kinds of responses. And what we'd like to talk about a little bit now is sort of the role that public health, particularly state public health, can play in contributing to controlling these kinds of things. So you've heard us talk about how we've got very close relationships, of course, with our public health laboratory, our regional laboratory through CDC, our CDC EPI colleagues, our local health departments, and of course all of the facilities that we work with, our infection preventionists, the clinicians, and the pharmacists in those settings. So what we're going to talk through sort of briefly is the approach that we're using at this point in Nebraska to mount a response to carbapenem-resistant Enterobacteriaceae. And this is something that we've outlined pretty clearly. We've actually developed a guideline that you can find on our website. There's also a CDC guideline that is also on our website. But as we talk through this, I think that what you'll find is that, and I think that what we're all going to experience, this approach, right, this idea, it's not going to just be for carbapenem-resistant organisms. I think that the more resistance we start to see, the more concerns, you've already heard about some of these emerging concerns, Candida auris or Acinetobacter. This idea of working collaboratively to contain these kinds of resistance before they spread is going to become more and more common. Oh, we went backwards, let's go forwards. So again, the role of state public health here, and you've heard us sort of talk about the regulations that we have in place, which gives us sort of a little bit of bite behind our bark, right? When you have one of these organisms, we really want to hear about it in the public health department. And the reason is because we can offer sort of a little bit of additional support. And I can tell you that when I've done these kinds of things, there are some people who need only a little bit of support, just want to check in and sort of let us know what's going on. And there are other people who would like us to drive out and sort of provide on-site support. And we can kind of do a range of activities in between. But we've spelled out pretty specifically what the public health and epidemiologic approach to this is. And so you'll see the information that we look at. And we're looking, of course, as public health professionals and epidemiologists, to try and understand some of the demographics. But we're also trying to look a little bit about the risk factors, right? That's part of public health. And we're trying to define how we think these things are moving. You've heard Dr. Tierney say, knock on wood, right? Wherever there's wood. We're not Chicago yet. We're not New York yet. And so we're trying to figure out how these types of resistance are moving so that we can better address what's going on. And I can tell you that one of the biggest risk factors we've found, and something that's really important to keep in mind, is the risk of having health care outside of the country. I can tell you that in most of our cases, probably all of them that weren't KPCs, this was the risk factor that we identified. And it's a priority for CDC as well. So in addition to sort of collecting some public health epidemiologic information, another part of the response is going to be infection control, right? And you heard from Kate Tyner, who knows this better than I do, about the kinds of things that we would implement. And I'm sure that these don't look too strange to you. Things like good hand hygiene, using contact precautions when you need it. But you'll see at the bottom there, one of the really important ones, and I can tell you that the more times we've done this, this has become increasingly sort of the thing that tips the scale in managing this, is stewardship. Making sure that we're choosing the right drug for the right patient at the right time is almost impossible to control some of these things without having that stewardship piece in place. And so again, these are just a couple more of the infection control recommendations that we'll make, and you have all of those spelled out there in front of you. And again, these are also all available on our website. But again, it's things about thinking how to sort of control the spread of this kind of organism. And as you heard from Dr. Tierney, this kind of resistance is a particular concern for public health because we're not just talking about something that can, move from person to person. It can move from bug to bug. And when that sort of thing happens, again, you can find yourself as a pharmacist or clinician really with no good treatment options, which is a scary place to be. So one of the other things that public health can assist with, and one of the other ways we've sort of tried to address these kinds of outbreaks of emerging resistance, is to think about screening. And this might sound a little bit familiar. I know there are some of you who've probably heard me give this talk. And this is similar to sort of the idea of screening for other organisms. But what we're trying to get at here is when we hear about this kind of organism, it's concerning because you've got a resistant bug, right? We're trying to get some epidemiologic information we're trying to implement some control measures, but one of our biggest focuses as public health professionals is, are there other people whose health is at risk that we need to protect? And so one of the things that we'll do is we'll work with facilities, clinicians, providers, to identify whether we think there's anybody sort of related to that initial case, right, in a ring around that first person who could have potentially been exposed and now become colonized with these resistant organisms. And again, the reason is that at this point, one of our best ways to combat this kind of resistance, in addition to the stewardship approach, is to at least know who has this and try and put a ring around and control measures around those people. And so typically what we'll do is we'll work pretty closely with facilities, and we have a set of recommendations that we make. And again, I know this is a bit lengthy. You can find all of this in our protocol on the website. But what we do is we work closely to try and identify, again, who are those people who are at greatest risk. Coming from the public health perspective, that's really what we're trying to get at, is there a risk to somebody else that I can prevent? Oop. Back one. The other piece of this, and you've heard several people say this now, I can't emphasize enough how important the collaborations are in doing something like this. This is not sort of a one-man show, right? It really takes the work of public health, working closely with laboratorians, working closely with infection control, pharmacists, clinicians, and certainly our laboratorians in this situation are very important, and we've come up with a pretty good system both at our state lab and with our regional labs for how to do this. So I want to shift just a little bit, and we've got some time, to talk a little bit more about what you've heard about the registry that we've developed. So again, through the tremendous foresight of our state epi, Dr. Tom Safranek, and the tireless work of Dr. Maureen Tierney in getting those regulations passed, we found ourselves in Nebraska in a unique situation. So as you've heard, again, CRE is a nationwide concern, and I can tell you that in a lot of other places what they're doing is they're having to look for a particular organism with a particular resistance pattern. And that is kind of difficult to do both technically and practically, as you might imagine. So we've got the benefit now of having, because of our regulations, we receive electronic lab reports of the series of organisms that you saw before. We received those results along with their full susceptibility patterns. And it's allowed us to start to get some really good insight into what we think might be going on in the state. And it's also allowed us to start to develop some surveillance systems for how to pick up concerning resistance. So what you're looking at here is the time graph of when we started collecting this information. We did have quite a bit actually before January 1st, 2017, but this is for the 2017 year after those regulations took place. And you can see that it took us maybe a couple months or so to kind of get all the labs up to speed and get where we needed to be. But we're receiving some great information at this point. So I can tell you that for 2017, we had about 70,000 isolates from 28 facilities across all 20 of our local health department jurisdictions, as well as several out-of-state jurisdictions. And this amounts to about 6,000 reports per month. And when we reduce that, and I'll talk a little bit more about why we do that and how, comes to closer to about 62,000 when you restrict it to one isolate per patient. But what we've done is the way we get this information, and again, Dr. Safranek, I'm sure could talk more about this than I could, but we've coded a program that pulls from electronic messages the relevant pieces of data. And we've actually coded for over 101 different antimicrobials, so it's a pretty robust program. And I can tell you that we receive quite a few reports on species in excess of what's in the regulations. Sometimes this happens because it's easier for a facility to simply say, okay, we're going to sort of give you these results rather than cherry picking. But often it happens because patients will have infections that are polymicrobial, and so we're getting multiple results for multiple organisms. And so this just gives you a little bit of a sense, as you can see, of the diversity of the kind of organisms we're getting. And so this is a little bit more of an updated summary that I pulled a couple of months ago, and at this point we were getting about 1,300 reports a week on about 40 species pretty reliably. We get good data on about 25 antimicrobials, and at this point we've got 34, 35 facilities reporting. So we're still, I would say we probably have close to 90% of the facilities, if not more, on board, and we're just sort of making sure that we pull people along. And the process of doing this, right, is pretty labor intensive, and it's an ongoing process. There's always going to be, as you heard this morning, new laboratories, new technology. That's part of the reason why having a lot of our good collaborations and relationships in place is so critical. So getting back to what we've been able to do with some of this data, you heard us talk about a registry or a susceptibility data registry. We actually now have a really great registry. It's a CSV file, line level data, right, which all of us epidemiologists love. And it's pulling that direct information for each result along with its susceptibility from the hospital into our secure servers. And so practically speaking, what we've already been doing with this information is using it to perform surveillance screening for CREs as well as visas and versas, which you heard were sort of two of our priority concern organisms. We've also been able to use this to look at clusters of MDROs, or even just clusters of resistant outbreaks, not necessarily MDROs, but just organisms with a particular pattern or a particular type of organism. And it's been very helpful to kind of have this to go back to look at whether we get a call about, a problem in a facility. Do we think this is just happening in this facility, or do we think there might be something more going on? And as I'm sure you all know, these kinds of organisms we've seen again and again. This resistance can be amplified in some of the long-term settings or, some of these tighter communities, and you can start to see spillover. So it becomes not just a problem for one institution, but more of a generalized issue. It's also going to allow us to follow resistance over time, which is going to be really nice. But so you heard a little bit about antibiograms this morning, and we've actually been able to develop a program that has created a statewide electronic lab reporting antibiogram. And again, I can tell you that this is because of Dr. Safranik's foresight, but there's no other state in the country that can do this right now. So what we do is we have a program that runs every night in real time, and I pull the previous 365 days worth of data. And we're using the interpretation that we're getting from the laboratory. And you can rely, we get interpretations as well as MICs, but we're relying primarily on the interpretations at this point because it's more comprehensive. And we restrict that to one isolate per patient per analysis period, which is in keeping with the CLSI guidelines that you heard about this morning, and reporting only when there's more than 30 isolates tested. But what's really nice about this is that it populates automatically every night. And so I can come in, and I do, and check our 5 gram-positive organisms here, along with the, you can see the percent susceptible and the number tested. And then 14 gram-negative organisms here, again, number tested and percent susceptible. And it's been a really nice source of information, again, which we wouldn't have if it weren't for the support of lots of other people, including several folks at our local health departments who have helped us do this. But it's been a nice way to do some surveillance for detecting not only CREs, but other resistant organisms, which we've continued to do. We've also been able to apply this practically. We issued a health alert network message several months ago related to flu. Flu was a tough year this year for everyone. And we wanted to make sure our providers were aware of their treatment options, not just the antivirals, but if they were having patients coming back in with post-flu bacterial pneumonia, if they met those clinical criteria, of course, we wanted to be able to provide them with a little bit of insight and information on what the resistance patterns for staff might look like in this area. So that was actually a really nice application. And then we're also continuing to use this to screen our data for any sort of concerning or unusual resistance patterns. So what we're hoping to do is continue to develop this, make these antibiograms more available, look at them regionally by our local health departments. We're hoping to develop a little bit more of a robust surveillance system for detecting multi-drug resistant organisms. And of course, as always, we want to continue our collaborations with all of our partners, all of you guys here today, and hopefully with Iowa as well soon. Turn it back over to you.
Now you see why I'm so sad she's leaving? I'm just crying every day, actually. So, just to very quickly wrap up, we're going to go back to Apollo 13. Now, to tell you, so you really understand how much I love this movie, at my last auspicious birthday, I won't tell you which one it was, my husband and sons decided to get me an Apollo 13 birthday cake. So this is, it's a little obsessive. But, you know, the closing remark, the thing I quote all the time, you know, failure is not an option. And interestingly enough, that's not an actual quote from the actual events. What had happened is that Ron Howard and folks went and interviewed a lot of the individuals at Houston, and they described, they said, you know, when you were in the midst of this terrible scenario, how did you manage to keep calm? How did you work it through? And they said, well, when bad things happen, we just calmly laid out all the options, and failure was not one of them. We never panicked, and we never gave up on finding a solution. So for almost any problem, and antibiotic resistance and high rates of C. diff are a problem. And when we work together collaboratively, Department of Public Health, Antibiotic Stewardship, our programs at Nebraska Medicine, NPHL, infection preventionists, I truly think that we will continue to make inroads into this problem.